It is my great pleasure to introduce Dr. Michelle Monje, MD, PhD, as our speaker for today. Dr. Monje is professor of neurology at Stanford University and a Howard Hughes Medical Institute investigator. She received her MD and PhD in neuroscience from Stanford and completed her residency training in neurology at Massachusetts General Hospital, Brigham and Women's Hospital, Harvard Medical School Partners Program, and then returned to Stanford for a clinical fellowship in pediatric neuro-oncology. Her research program focuses at the intersection of neuroscience, immunology, and brain cancer biology, with an emphasis on neuron-glial interactions in health and oncological disease. Her lab discovered that neuronal activity promotes the progression of malignant gliomas, driving glioma growth through both paracrine factors and through electrophysiologically functional neuron-to-glioma synapses. Dr. Monje has led several of her discoveries from basic molecular work to clinical trials. Her work has been recognized with numerous honors, including an NIH Director's Pioneer Award, a MacArthur Fellowship, the Richard Lounsbury Award from the National Academy of Sciences, and election to the National Academy of Medicine. Dr. Monje has a strong relationship with ALSF, receiving 4 research grants, including an A Award, 2 Innovation Awards, and a Research Catalyst Award from the Foundation, along with serving as a member of our Scientific Advisory Board. As a programming note, we will have a Q&A session after the presentation, and you may ask questions to Dr. Monje using the chat feature. On behalf of ALSF, I wanted to thank Dr. Monje for her time today, and we'll pass it over to her for a presentation titled GD2-CAR T-cell Therapy for Diffuse Midline Gliomas. Thank you very much, Dr. Monje.
Thank you for that wonderful introduction, Justin. It's so nice to join everybody. So I'm going to have the opportunity to tell you today about our experiences at Stanford with CAR T-cell therapy for diffuse midline gliomas. And as Justin mentioned, as many of you may know, I've been studying diffuse midline gliomas, including diffuse intrinsic pontine glioma and similar tumors that occur in the thalamus, spinal cord, and other midline structures of the nervous system for the majority of my career, ever since I first encountered this disease as a medical student. And I think that, as many on this call know, this is a terrible cancer. These are really amongst the most dreaded childhood cancers. It's the leading cause of brain tumor-related death in children, adolescents, and young adults. The median survival is only 11 months for the pontine version of diffuse midline gliomas and only 13 months on average for non-brainstem diffuse midline gliomas. The 5-year survival rate is less than 1%. And we know from the work, from many labs across the world, including mine, that this is a disease that is driven by the pathogenic effects of a very specific mutation in genes encoding histone H3, H3K27M, which drives oncogenesis in cells that originate in the oligodendroglial lineage, so early oligodendrocyte precursor cells in the developing nervous system. And over many years, we have uncovered that, this cancer actually integrates both structurally and electrically into the neural circuits that it invades in the brainstem, thalamus, spinal cord, and throughout the nervous system. This happens in part through, bona fide electrophysiologically functional synapses, both glutamatergic and GABAergic synapses. And this electrical activity, which you can see here in this calcium imaging movie of a DIPG, really underscores that this is not just a structurally integrated cancer, it is an electrically active tissue. And so how do we approach this? This cancer that is integrated into the nervous system, how might we therapeutically disintegrate it? Around the time that we began to really understand this and make the discoveries about the neuron to DMG synapses, this was when CAR T-cell therapy, chimeric antigen receptor T-cell based immunotherapy, was showing so much promise, began to show so much promise in childhood leukemia. And around that time, Crystal Makel came to Stanford. And so I started thinking, maybe we could use an immune cellular therapy to very specifically target and disintegrate these cancer cells. And so a really wonderful MD PhD student in my lab, Chris Mount, had the idea that we could screen the surface of DMG cells using the patient-derived DMG cultures that we have from patients who donated their tissues to our laboratory. And what we found was that there was extraordinarily high levels of a glycolipid, a dicelluloganglioside called GD2 on the surface of H3K27M mutant diffuse midline gliomas. And it's very specifically on the mutant form. There is a small fraction of these tumors that happen in the absence of this mutation specifically. And we did not find elevated GD2 expression on those tumors. So it was very exciting that in the H3K27M mutant form of the disease, which represents, 80+% of tumors, there was this very, very high, very uniform expression of a really good immunotherapy target. And the reason that it's so high in the H3K27M mutant cells is that the epigenetic dysregulation induced by the H3K27M mutation drives up the expression of GD2 synthesis genes. And so once we had this discovery, I walked over to Crystal Makel's office, whose office is conveniently in my building here at Stanford, and said, I think you just made a new generation of a GD2 targeting CAR T cell. It would be amazing to test that in our preclinical models together. And while many of the people in the audience are very familiar with CAR T-cell therapy, I just want to review what this is. This is the opportunity to take a patient's own T cells, so harvested through apheresis, express in those cells a chimeric antigen receptor, which has the sort of, a very specific binding portion, from an antibody on one side, and then the activation machinery for lymphocytes on the other side of this chimeric protein. Once these chimeric antigen receptors are expressed in the lymphocyte, they're expanded and then returned to the patient, where they very specifically induce cytotoxicity of cells expressing high levels of that target antigen. And when we put the GD2 targeting CAR T cells that the Mako lab had developed into our patient-derived xenograft models of DIPG, thalamic DMG, and spinal cord DMG, we saw that the tumors really just kind of disappeared. And they disappeared when administered intravenously between 7 and 14 days. We're measuring this here using in vivo bioluminescent imaging, where you see that mice treated with a control CAR T cell, CD19 CAR T cells used for leukemia, that we wouldn't expect to interact with DIPG, has no effect. When we look using a different method, microscopically, when we end the experiment and look at the mice under the microscope, we see that these green and purple tumor cells that are diffusely infiltrating the brainstem and the cerebellum of the control CAR T cell treated mice are really, just absent from the GD2 CAR T cell treated mice. So it's a lot easier to treat a mouse than to treat a patient, but I had never seen anything this effective in our mouse models. And so, with the idea in mind that, of course, it's going to be more challenging in kids than in mice, and also keeping in mind how potentially dangerous it is to cause therapeutic inflammation in critically, functional and really delicate structures like the brainstem and spinal cord. We opened this phase 1 clinical trial of autologous GD2 CAR T-cell therapy for DIPG and spinal cord DMG. We opened this in the spring of 2020, so right in the sort of beginning of the COVID-19 pandemic, which is a whole other story. But we did get it open and begin recruiting in the spring of 2020. I want to just note that, I mentioned the anticipatory measures that we felt we needed to include to safely administer a robust immunotherapy in these midline structures, which are so neuroanatomically precarious. And in our mouse studies, we found that the thalamus was a particularly dangerous place to induce inflammation. This is intuitive for anybody who's trained in neurocritical care. That is a structure that is positioned to potentially herniate across the tentorial notch. And so any swelling in an already expanded thalamus can be rapidly fatal. And the mice did not tolerate thalamic CAR T-cell therapy as well as they did in other locations. So until we had more experience with the therapy, we wanted to leave thalamic disease out and just focus on the pons and the spinal cord. Now that we have a lot more experience, we've just added a high-risk arm to the trial to treat patients with thalamic DMG. So the plan for the first arm of the trial, which is what we have the most mature data for, and which I'll spend the majority of the talk telling you about, I'll then in the end tell you kind of what we've done since this arm. The plan was to administer a dose of autologous CAR T-cell therapy at one of two dose levels. First, intravenously. So that was how we had delivered CAR T-cell therapy for the mice, was IV. We thought, IV administration is a bit of a more natural way for lymphocytes to traffic to the nervous system. And perhaps importantly, we expected sort of a flattened curve of inflammation, right? The CAR T cells won't get there all at once. And so we might be able to manage the inflammation in these very delicate structures a little better if the administration was IV compared to other routes of administration like intracerebroventricular or any intracranial administration. We did this after the standard lymphodepleting chemotherapy regimen using fludarabine and cyclophosphamide as the LD chemotherapy regimen, based on other CAR T-cell trials. This is the regimen used in leukemia and other solid tumors. And then after 3 days of lymphodepleting chemotherapy with fludarabine and cyclophosphamide, there's 1 day of rest. And then we administer the CAR T cells intravenously, either at 1 million CAR T cells per kilogram of patient body weight or 3 million CAR T cells per kilogram of patient body weight. And we did this in an intensive care unit setting. Again, it's the brainstem, it's the spinal cord. We really felt we needed to be very, very careful, and that quickly was evident that it was the right call. We have to do this in a very closely monitored setting. We kept kids in the hospital for a couple of weeks, at least, to monitor for toxicity and manage toxicity. And then if they exhibited benefit, either radiographic reduction in the tumor size or neurological improvement, they were then eligible for subsequent infusions of CAR T-cell therapy, which we administered now intracranially. So this is, I guess we can think about a little bit like induction, and the intracranial subsequent administrations are a little bit like maintenance. We need to be really careful, and we knew we needed to be really careful. And the things that we need to be really careful for include cytokine release syndrome. This is a major issue with all potentially a major issue with all CAR T-cell therapies. Certainly proved to be a major issue following IV administration of CAR T-cells on this trial. Immune effector cell acute neurotoxicity syndrome, or ICANS. This is an acute delirium syndrome that's seen quite frequently with CAR T-cell therapy for leukemia. We anticipated seeing quite a lot of it when we were giving CAR T-cell therapy for a CNS cancer. Really interestingly, as I'll show you, we did not see a lot of ICANS on this trial. Instead, what we expected to see and what we absolutely saw were the symptoms and issues attributable to inducing inflammation in the location of the tumor. So causing inflammation in the brainstem, we would expect to make the brainstem function somewhat less well. And also, we worried about the effects of inflammation-induced edema and potential tissue shifts in a very tightly constrained anatomical compartment, right? The cranium keeps the brain and brainstem, and the spinal cord, the spine keeps the spinal cord in a very small and fairly inflexible container. And any kind of increase in pressure, increase in swelling, shifts of tissue are not well tolerated. And so we worried about the space limitations caused by edema or increases in pressure. It's kind of a mechanical problem. And so we thought of that as one type of tumor inflammation-associated neurotoxicity. And another type of problem is sort of a more of electrical problem, neural circuit dysfunction because of inflammation in that location. And, this can be very well tolerated if the tumor is located in, for example, a language area, then we might have a decrease in language function transiently, and we can tolerate that. But if the tumor is in, for example, the cervical spinal cord, where the control of the respiratory musculature, or the lower medulla, where the upper control of the respiratory musculature is located, then that can cause really immediate and difficult to tolerate issues with breathing. So we wanted to be really mindful of those potential consequences of CAR T-cell therapy. And what we saw was that in each of these graphs, and what I'm showing you is the number of patients and the degree of toxicity they experienced in each of these categories. So no toxicity at all is blue. Grade 4 toxicity is red. And you can see that in this first IV administration, the first infusion is always IV, and then the subsequent infusions are always intracranial into the Ommaya catheter in the lateral ventricle, or intracerebroventricular, ICV. This first IV administration was associated with frequent cytokine release syndrome and high-grade cytokine release syndrome. And we saw higher grade cytokine release syndrome with the higher dose level of IV administered CAR T cells. And we actually had 3 dose limiting toxicities due to high grade CRS with that first IV infusion. In contrast to CRS, we saw very little ICANS. We did have some low grade ICANS. We had 1 case of grade 3 ICANS in a young adult patient with a spinal cord tumor who at the same time had urosepsis. So not entirely sure whether it was ICANS or urosepsis-induced delirium, but in general did not see ICANS with any of the intracerebroventricular administrations. And this was actually quite a big surprise. I thought that by inducing so much inflammation in the nervous system, we might see a lot of ICANS, and I think that just speaks to how much we still need to learn about the pathophysiology of ICANS, which occurs much more commonly in CAR T-cell therapy strategies for leukemia than it seems to for DMG. What we expected to see and definitely saw a lot of, though, was tumor inflammation-associated neurotoxicity, the symptoms attributable to inflammation at the site of the tumor. These were very localized to exactly what we would expect given where a tumor was, tended to be, almost all cases were transient, but required critical care management in many instances. So we saw high-grade TN both with IV administration and with ICV administration. That said, because we had these anticipatory measures in place, including every patient had an Ommaya catheter in which we could monitor intracranial pressure, we could treat hydrocephalus immediately with a butterfly needle in the Ommaya. We didn't have any dose-limiting toxicities attributable to TN, and that really speaks to the importance of collaboration between pediatric oncology, neurology, neurocritical care, and neurosurgery. Here is a waterfall plot that shows the best radiographic response for the patients infused on Arm A. We had really the entire sort of distribution of potential responses. So we saw, everything from growth through the therapy to one child who had a complete response that remains durable to this day. So, and everything in between. And there were not outliers. The responses were normally distributed. They fit a Gaussian distribution and really fit the entire gamut from 0% reduction to 100% reduction. This is the swimmer's plot for the overall survival for patients on the therapy. There's a lot on this graph, so just to orient you, the yellow component shows you how long a patient had the time period between diagnosis and enrollment and treatment on the trial. Some patients came to us relatively soon after diagnosis. Others, lived for some time and were on other therapies prior to coming to this trial. The star here shows you the date of enrollment, and the line is the time of infusion. So it was typically just 2 to 3 weeks from the time of enrollment and CAR T-cell manufacturing to infusion, sometimes a little bit longer, for example, because of the holidays. And this is how kids did after the trial. You can see that each tick mark here is an infusion. So some kids just got 1 or 2 infusions. Some received many infusions over a longer period of time. And one patient is still on the trial and alive today. I want to take you through, our experience in sort of a case series to tell you some examples of how kids did. This was a somewhat older patient diagnosed at age 19 and came to the trial at age 21. He exhibited a moderate reduction in his tumor volume, about a 25 to 30% reduction in the tumor volume, but with that came a marked improvement in his neurological exam. And one example here is seen, this is this dense seventh nerve palsy, facial droop on the left. And just a couple weeks later, you see full return of seventh nerve function, and this, beautiful big smile. During the initial infusion, this patient had a really good example of type 2 TN, that kind of electrical dysfunction of tumor inflammation associated neurotoxicity with transient worsening of pre-existing neurological symptoms. So he had difficulty together with the seventh nerve palsy. There was also fifth nerve dysfunction, and he had fairly moderate to severe trismus. He could not open his mouth fully. And during inflammation, this became quite severe. He could actually only open his mouth for a few days sufficiently to drink from a straw. By the end of that course, though, he could open his mouth fully and was eating cheeseburgers again, which was his goal. So we were really happy to see that. He did really well for a couple of months. This was the second DIPG patient treated on the trial. And then unfortunately began to exhibit progression around 3 months following this first CAR T-cell infusion. And this pattern is something that after the first few patients, we recognized we had persistence for most patients for a couple of months, and then they needed retreatment. So after 3 months, he began to have worsening of his neurological exam. He had been in early progression when we started to treat him. Progression resumed, and he had worsening of his fifth, sixth, seventh, and eighth nerve palsies, to right hemiparesis, right hemisensory loss, and a very ataxic gait requiring wheelchair use. We then gave him an intra-Ommaya infusion of 30 million GD2-CAR T-cells. He had fever, headache, nuchal rigidity, and nausea, vomiting beginning that night. We were measuring intracranial pressure, through a butterfly needle in the Ommaya, and that was normal until the second day. And then with continued headache, fever, and nausea, vomiting, he suddenly became somnolent, developed a new third nerve palsy, and when we measured his ICP, it was 34. So this is the type 1 TN. This is a mechanical problem. He had developed obstructive hydrocephalus because of edema in the already expanded pons and obstruction of the fourth ventricle. We left the butterfly needle in the Ommaya that continued for continuous drainage. He immediately improved, woke up, the third nerve palsy resolved. We confirmed that he did in fact have obstructive hydrocephalus, and we gave him a short course of steroids, just less than 4 days. We were able to de-access the Ommaya after 2 days. We transferred him to the floor. He was actually able to discharge by day 11, now off steroids for a full week. And this is the change in his gait. So the first video I want to show you is his walking just prior to the second infusion. And you'll see that he's very unstable, very wide-based gait. There's right-sided weakness that's evident in this right circumduction. Needs multiple steps to turn. As he walks back on his toes, that accentuates the right hemiparesis. And he's going to attempt to tandem walk, but actually he falls and I catch him. And then just 2 weeks after this ICV infusion, this is his gait in clinic. Much more stable, much faster, turns with just 2 steps. A little bit of that right hemiparesis that actually continued to improve his gait became almost completely normal over the course of several more weeks. And he had continued improvement or stability for about 6 months. And then unfortunately, his tumor progressed. A next case is a 5-year-old female with DIPG. She had had a very nice response to initial radiotherapy, but residual was this tumor here in her right in the corticospinal tract of the midbrain, in the cerebral peduncle. And this on the left side was resulting in fairly functionally significant right hemiparesis. She was unable to use the right hand. She kept the hand in a sort of, with increased tone in this flexed position, couldn't play with it, couldn't feed herself, had a right sort of spastic gait on the lower extremity. And quickly, after the first IV infusion, we saw this reduction in the T2 abnormality in the corticospinal tract. And with that, she regained full use of this arm. She was able to open and close her hand by just like a week later, was able to start to use her hand to feed herself and in play. Her right leg also improved. She began to learn to ride a scooter, pushing off with the right leg. So this marked improvement in right-sided spasticity and weakness was accompanied by improvement in balance and coordination. She had chronic nausea from the very beginning of her disease course, and actually was, at a very low growth curve, and the nausea resolved within days. Actually, even in the ICU, she was eating In-N-Out burgers and really started to thrive. We saw her grow 5 centimeters in 1 month after her appetite returned and the nausea resolved, and she jumped a couple of curves on her growth curve. She had improved control of secretion, improved drooling, improved hypophonia. Her voice became stronger, but unfortunately, she developed new disease in the cerebellum that was really growing. So we retreated her at 3 months after the first IV infusion, intracerebroventricularly. She tolerated that very well, but had a mixed response. She had further improvement in the brainstem disease, further improvement in her right-sided motor function. Adorably regained the ability to wiggle her big toe and was very excited about that. But unfortunately, disease continued to progress in the cerebellum, and she died from the cerebellar disease. So here you can see in the midbrain, this initial kind of pseudo progression after IV administration, and then this nice reduction that continues in the burden of disease in the corticospinal tracts in the midbrain. But if you look here at these pink dots, this is the cerebellum, very little to no disease in the cerebellum. It then spreads and just continues to increase. And this was the disease that caused her death. And something that I've noticed over the last 5 years of this trial is we seem to have fairly consistently nice responses in the brainstem, nice responses in the medial temporal lobes in general, really poor responses in the cerebellum, and fairly poor responses in the cortex. And so different neural regions, different neural circuits seem to portend a different response to the CAR T-cell therapy, even in the same patient with the same tumor and the same antigen expression. And so we're really working hard in my laboratory right now to understand these neural influences on CAR T-cell therapy. The next patient is a 25-year-old medical student, actually, with an H3K27M mutant spinal cord DMG. This was a tumor, as many of them are in young adults, centered around the lower thoracic cord, around T10. Following surgery and cord radiation, she enrolled on the trial, but unfortunately, she was in rapid progression and developed near complete paraplegia with tumor spread to her brain during the couple of weeks in which we were enrolling her and making the CAR T cells, just as a reminder for anybody who needs it about how quickly this disease can change and spread. We took her off the trial and decided to treat her on a compassionate basis. In that time, we also had emergent duroplasty to decompress the spinal cord. This tumor was just so rapidly expanding before we treated her that we needed to give her a little more space for her cord. And then we treated her with a single patient IND. She, with the first IV administration, had grade 3 CRS, but otherwise tolerated the first administration very well. She had a dramatic response in her cord, which I'll show you, and no response in the brain. With the cord response, she regained some motor function in her legs. She began to be able to move her legs, anti-gravity. She could walk with harness support in physical therapy. She had been incontinent of urine and regained full independent urinary function. But unfortunately, and again, this is one of the first patients we didn't know we didn't know when to retreat back then. She also progressed at 2 to 3 months and returned to Stanford for retreatment. So here's her tumor. I'm just going to highlight it so it's a little bit easier to see. Before treatment, fairly large, intrinsic to the spine, to the cord tumor, extending across multiple vertebral levels. And it begins to quickly reduce in size and volume. And actually, she had a 90% reduction here with the first IV infusion. And then it began to grow again. She came back for another infusion and had an 80% reduction in her cord volume. And here's just measurements of the volume of the cord in 3 dimensions. We had a wonderful neuroradiologist named Kristen Yom who did careful segmentation of the tumor and 3D volumetric measurements. And you can see this decrease in tumor volume over time and then increase again until the second infusion with a second decrease. But in contrast, this spread to her medial temporal lobe, which often in other patients, actually that location responds. Here we did not see a response. We see this diffuse spread to the medial temporal lobe. It grows over time and it grows through that first infusion. We had this before the second infusion. We actually had this resected because we were worried about uncal herniation. And with the resected tumor tissue, we looked for GD2 antigen to see if perhaps a difference in antigen expression explained this difference in responses in the different locations. And actually, she had very high levels of GD2 in the resected tissue. And this is consistent. When we look at autopsy samples from our patients, we see very high GD2 expression there as well. So antigen loss or differential antigen expression does not explain treatment failure. Another spinal cord patient treated on dose level 2 of arm A came to us in extremis. She developed complete paraplegia and pretty profound incontinence of both urine and stool. This is her tumor pre-infusion, and we saw the tumor decrease. It took a few months, but it began to decrease over time. By this point, we knew that we needed to retreat after about 4 to 6 weeks. We couldn't let the tumor begin to progress at 2 to 3 months. And since we had that understanding, we've been treating everybody every 4 to 6 weeks with repeated ICV infusions. Let me just show you this tumor in cross-section. You can see this large tumor affecting the entirety of the spinal cord and completely filling the spinal canal. And then it reduces, you see this return of CSF around the cord, and there's just this sort of T2 smudge here. When she began the trial, she was wheelchair bound, fully paraplegic, and incontinent of bowel and bladder. By 9 months, she was walking with a cane and fully continent of urine and stool. She had a pretty dramatic volumetric decrease in her tumor, as you could see by those images. But when we measure, we see this over the first few months. As I mentioned, it did not decrease for a couple of months. In part, I think it was growing incredibly quickly, and we slowed it down here, and then it began to decrease by about 3 months. Then she had a marked reduction in tumor volume that she maintained. There's still a little bit there. And then unfortunately, she began to progress around here, around a year. And when we look at a couple of correlative measures, we can begin to understand that. So here in the blue dots, I'm showing you CAR T-cell persistence detected in the blood. And she has really good CAR T-cell persistence until about a year, and then she loses it. And the CAR T-cells become undetectable here. At the same time, if we look at the tumor cell-free DNA, measuring the H3K27M mutation in CSF, her cell-free DNA is fairly low until we have this inflection point. She loses CAR T-cell persistence, and then the cell-free tumor DNA begins to increase in her CSF. The best news was a patient who was 16 years old when diagnosed, 17 when we treated, and is now 20, nearly 21. He came to us with a fairly large biopsy-proven diffuse intrinsic pontine glioma affecting, you can see this, there's a nodular component that's entirely obstructing the fourth ventricle, and then this diffusely infiltrative component throughout the pons, and the middle cerebellar peduncles back into the cerebellum a little bit, affecting the medulla and affecting the midbrain. He had a dramatic reduction. You can see that the midbrain just completely normalizes. The pons, this large nodular component, entirely disappears. He still has some T2 abnormality around the middle cerebellar peduncle. This is also where his biopsy was done, but this is clearly more than just the biopsy tract. There's more T2 abnormality. You can see this return of CSF here. You see return of the normal fourth ventricle, and the medulla looks nearly but not completely normal. And then by 5 months, here's the biopsy tract. Here's a little bit of olivary hyperplasia that we continue to follow, but just really dramatic normalization of his brainstem that continues to this day. So he is now 44 months from no, hang on, how many months this is covered? 40. It'll be 4 years and 2 months. So he's 46 months from beginning therapy. And he's had, together with this, dramatic radiographic reduction, the biopsy tract continues, but we don't think that that's tumor. And he's been stable now for years. We are calling this a complete response. He's, together with that, gone from needing assistance to walk to walking independently. He's actually now starting to jog again. He's hiking. He's a forestry major and hiking in the forest. He's had return of sensation to his hemi face and hemi body. He's had improvement in his left-sided hearing, which had been deficient. And here's just a couple of videos to show you changes in his gait. This was right after the first infusion. His family went up to the redwood forest in California. He was in a wheelchair, but wanted to walk across this bridge, and his father has to hold him up because of his severe ataxia. And then 20 months after the first infusion, they return to the redwood forest and he walks across the bridge alone. And his, gait has just continued to improve. Looking at volumetric measurements, you see the volume of his tumor here before treatment. It decreases to essentially nothing and then remains so. At the same time, when we think about his correlative studies, here is his CAR T-cell persistence in blue in the peripheral blood. And while it decreases somewhat over time, it remains measurable to this day. In contrast, he started with pretty high H3K27M detectable cell-free DNA in the CSF. Together with the reduction in tumor volume, that decreases to undetectable and remains undetectable. So how can we achieve that for every patient? How can we achieve complete and durable responses for every patient on the trial? What's different about the kid who had the complete response, and how can we achieve that for everybody? Well, one, set of questions is, how do we optimize the dose, the route of administration, and the preconditioning, regimen? Do we give this therapy IV or do we give it ICV? Do we start with ICV? Do we need preconditioning chemotherapy? There are many trials, most trials actually, for pediatric brain tumors utilizing CAR T cells are not using lymphodepleting chemotherapy. So do we even need it? And what is the best, safest, and most effective dose of cells? We're learning from deep correlative studies that Alex's Lemonade Stand Foundation has been supporting over the years. We are measuring cytokines and chemokines in the CSF and blood. I'll show you some of that data in a moment. We're performing single cell sequencing of the cells present in the CSF, which are chiefly immune cells. And whenever possible, we're doing tissue studies of patients if they're ever rebiopsied. That hasn't really happened, but at the time of autopsy. And then from what we learn in the correlative studies, we can bring that, those insights back to my laboratory and test hypotheses from the patient data in the lab and see if we can target immune suppressive mechanisms to improve this therapy, if we can target potential mechanisms of pro-tumor inflammation. And in this way, we can iterate. We can learn from our patients, bring the knowledge back to the lab, test new potential ways to optimize this or combinations of therapies, and then ultimately bring that back to the patients. So what have we learned so far from the correlative studies? Number one, in terms of correlates of toxicity, we found that cytokine release syndrome was correlated with CAR T-cell associated IL-2. So the more, the bigger the CAR T-cell response, the more risk for CRS. That makes sense. But also, I think really importantly, myeloid associated chemokines, MCP1, CCL2. TN, tumor inflammation-associated neurotoxicity, correlated with myeloid-associated chemokines and cytokines. You see that those who had low-grade TN compared to those who had high-grade TN had elevated levels of CSF, TNF-alpha, which is made by microglia, MCP1, CCL2, which recruits peripheral blood monocytes and other myeloid cells, and IL-10. What can we learn so far about correlates of response? If we can, consider the best radiographic response of the patients and kind of divide the patients between those who had stable disease or a reduction in their tumor compared to those who had tumor growth, then we see that there is a response-related cytokine. It makes some sense that those who had higher levels of IL-2, so therefore, higher CAR T-cell, which is actually made by CAR T-cells, so higher evidence of a CAR T-cell response had a better overall reduction in their tumor. And progression seems to correlate with IP10, or also called CXCL10. Those that were responding had relatively high levels of CXCL10 evident in the plasma, and those levels decreased at the time of progression. So in summary, on Arm A, in which we gave one cycle of LD chemo followed by IV CAR T-cell administration and then subsequent repeated ICV CAR T-cell infusions, we enrolled 13 patients. 2 had become ineligible due to rapid tumor progression before we treated them. One of those 2 patients we were able to treat on a compassionate use basis. We had 11 patients who were on the trial. We found that the maximum tolerated dose of IV CAR T, GD2-CAR T-cell for this patient population was 1 million cells per kilogram. We had too much high-grade CRS at the higher IV dose. These responses, comparatively, and I'll tell you about the next arms of the trial, were relatively durable. And I think, it's difficult to make any comments about overall survival. This is a highly selected patient population. So I don't think we can compare median overall survival to the historical, number of 10 to 11 months. We found that on this trial, those patients with DIPG had an overall survival of 17.9 months. There's 1 patient alive now, more than 4 years from diagnosis and nearly 4 years from the first treatment. We also noticed that the spinal cord patients we treated on the trial had higher grade CRS than the DIPG patients, which is interesting. We then opened 2 more arms of the trial. We didn't know if we needed that IV infusion. That was certainly associated with higher grade CRS. We thought maybe we can avoid that step and go straight to the intracranial administration. And we don't know if we need LD chemo. So we opened 2 more arms of pure routine 4 to 6 week intracranial administrations, intracerebroventricular administrations, either without or with LD chemo. And what we found was that Arm B, where we did repeated ICV CAR T-cell infusions without LD chemo, we treated 14 patients, 12 with DIPG, 2 with DMG. We found that the maximum tolerated dose of ICV administered CAR T-cells with no lymphodepleting chemotherapy was 50 million cells. And what we saw was almost no CRS. So that, just giving the CAR T-cells intracranial definitely addresses the issue with CRS in the first infusion. But we did have higher grade TN at the higher doses. That was dose limiting. In general, the responses on this arm were very not durable. Most kids had an early response and it didn't last more than weeks in most of the patients. The DIPG median overall survival was 14.2 months. There is 1 patient with a spinal cord tumor who is still alive and still receiving therapy. And an interesting observation that I think is really important as we think about, mechanisms of hydrocephalus and things we need to worry about is that on this arm of the trial and subsequently, we have seen that some of the patients with spinal cord only disease developed communicating hydrocephalus. So it's not that the tumor is swollen and obstructing CSF flow, it's that there's something about the inflammation that's either increasing CSF production or decreasing CSF resorption. And when we see this, it is severe hydrocephalus. It's a severe communicating hydrocephalus that absolutely requires treatment. We can treat it just with a butterfly needle and the already existing Ommaya catheter, but this has to be administered even for the spinal cord patients in an intensive care capable setting. On arm C, which is currently the arm that's open, we are doing repeated ICV CAR T-cell infusions with LD chemotherapy, and that is going much better. I think that we can conclude, although we haven't published this, that the LD chemo makes a big difference. We have we discovered that when we treat patients with ICV administration right after LD chemotherapy, there's a lot more CAR T-cell expansion, and we have to be a little more careful with the doses. So whereas, 30 million cells administered not immediately after CAR T-cell, not immediately after LD chemo, very safe. We've given over 100 doses like that. When we do it right after LD chemo, it's a much, much more toxic regimen. And so we started an intra-patient escalation paradigm in which patients get LD chemo followed by 10 million CAR T cells. The next cycle, they get 30 million. The next cycle, they get 50 million. And then we stay at 50 million until they need repeat LD chemo to maintain a CD4 count below 200. And then they start all over again at 10. We've done this now in 6 patients. This has been a regimen that we've declared safe, and we're now in the expansion phase. We've also added a high-risk thalamic arm to this regimen, which we feel we have a really good handle on managing the toxicity. We've seen on arm C almost no CRS and much more manageable TN. The responses have been promising so far, but it's still pretty early on arm C. So won't comment on median overall survival. Those data are still maturing, but we have 4 of the 6 patients still receiving therapy and on trial. I want to show you a couple of cases from each of these, subsequent and unpublished arms. This was a patient that we treated on arm B. She was a 19-year-old college student who developed DIPG. She was an incredibly beautiful piano player and had lost the ability to play the piano because of her disease, because of both weakness and loss of coordination in her hands. And for about a month after therapy, she regained the ability to play the piano. And I just want to play this for you. Again, lack of durability of these responses on arm B. We're beginning from the correlatives to really understand why and really understand that we need to avoid anti-CAR autoimmunity. Another child on arm C who is now nearly 2 years into the trial, has received 19 infusions, had an immediate, I'm sorry, the 2-year patient is the next one. I apologize. This patient did not stay on the trial as long. This was a 9-year-old boy who had a reduction with the first infusion in his mass. You can see this at the level of the pons, lower pons and medulla. He did well for several months and then unfortunately progressed. This is a child, though, a 7-year-old girl who has been on the trial for nearly 2 years. She's had 19 infusions so far. She presented, and this is actually a very, very interesting, her chief complaint when she presented with DIPG initially was memory and mood changes. And she had this very expanded bilateral hippocampi. which actually I see a lot in kids with DIPG. And now on postmortem studies, we're studying, there's this very diffuse, you have to do the H3K27M stain to really see it, very diffuse infiltration of the hippocampus, I think fairly commonly. But she had very symptomatic hippocampal disease in both medial temporal lobes. They're very expanded. After the first infusion, you can see the medial temporal lobes just reduced down to a normal size. With that, her memory completely normalized, as did her mood lability. And we saw a reduction in her tumor at other levels as well, in the pons, and especially down here in the lower pons, upper medulla. You see this fairly dramatic reduction in this exophytic component of her tumor. And she's got a nearly normal neurological exam. She still very much has tumor in her pons. It has not resolved. It's not a complete response, but her neuro exam is near completely normal still. And she is, nearly 2 years on the trial. So she's doing very, very well overall. So what are the lessons learned here? Number one, and I can't emphasize this enough, with a robust immunotherapy regimen of any kind, safety of CAR T of immunotherapy in the brainstem requires a closely monitored inpatient setting and multidisciplinary approach, applying principles of neurocritical care management. To date, we haven't seen any on-target off-tumor inflammation, and we've looked very carefully on autopsy studies, as well as, radiographically. We've only seen GD2-CAR T-cells induce on-target, on-tumor inflammation, which is important because there are low levels of GD2 in the normal brain. Repeated dosing is both tolerated and promising, and this was really exciting to discover, because in leukemia CAR T-cell trials, for example, repeated dosing tends not to work because the mechanism of resistance is often antigen loss. That's not the case here. We are finding that ICV administration is better tolerated than IV administration from a CRS perspective. And we now are completing ICV only arms of the trial, now on arm C, which I think is the favored regimen. Lymphodepleting chemotherapy really does seem to be needed for even only intracranial administration of CAR T cells. The nervous system is not an immunoprivileged site, as we were taught in medical school. There's constant trafficking of immune cells from the skull bone marrow into the nervous system, and CAR T cells can be rejected. In general, and I think this is so hopeful as a neurologist, DIPG and DMG neurological deficits can be reversed with effective therapy. Of course, the big challenge is administering effective therapy, but it is so encouraging that this is a tumor that causes neural circuit dysfunction, but not destruction, right? It needs the activity of these circuits to grow. It doesn't destroy them. We can rescue function. And it's clear that a durable response is going to require a much deeper understanding of the tumor microenvironment, something that we and many others are working really hard to achieve. Lots of people to thank. Again, all of this was done hand in hand with Crystal Makel. Robbie Majner was the first co-PI of the trial. Jassi Amati was the second co-PI of the trial. And now, as both have graduated and moved on to wonderful independent careers, Kanwei Song here at Stanford is co-PI of the trial. We've worked very closely with Sneha Ramakrishna as in studying the correlatives and trying to learn from them. We're very grateful for support of this incredibly expensive trial, and a lot of it has come from Alex's Lemonade Stand Foundation, so thank you. And last but not least, the patients and their families who've been brave enough to participate in this trial. Thanks for your attention. Hopefully we have some time for questions.
Thank you, Dr. Monje, for that wonderful presentation, a lot of great information, and a lot of hope for what treatments could come. So there are a few questions in the chat. So I wanted to start with first, do you see any differences in responses between age? So does age play a factor, or does sex play a factor? Either of those in terms of responses?
Fantastic question. More consistently, I've seen an age effect. Some of our very best responses have been in older patients. And part of why that may be true is we know that this is a disease that's more aggressive in the younger nervous system. It's much more it grows much more quickly. And CAR T-cell therapy is kind of like a foot race, right, between the CAR T-cells killing the tumor cells and the tumor cells proliferating and growing. So one aspect is just how much more aggressive it is in younger patients, but there may be other important factors there too that we're trying to understand. There has been, well, we've seen some good responses in younger patients. The really big, more than 90% kinds of responses we've seen in teenagers.
Great. So a second question is, do you see a correlation between reappearance of the depleted lymphocyte population as the CAR T persistence wanes off?
Yes. There is definitely a correlation between the adaptive immune system of the patient and CAR T-cell persistence. And that's something that we're studying in a very focused way.
Great. So an additional question, are there differences in patients who received irradiation in terms of CAR T response?
Yeah, so when we did allow for reirradiation on the trial, but only in general, that happened much later in the disease course. After reirradiation, when we had sort of lost, CAR T-cell efficacy, the tumors growing, we allowed them to have local therapy. The next infusion typically went pretty well. We usually, were able to recapture some response, but ultimately, none of those patients stayed on the trial for much longer after that.
Okay. And another question is, in metastasis patients with brain mets, if it is not antigenic loss, have you looked into other factors such as soluble or other signaling pathways that may override the effects of GD2-CAR T?
Yes. I have like 5 people in my lab working on this. A little teaser, the neurons matter a lot. And signaling molecules from neurons in different neural circuits are strongly regulating the fitness of the T cells.
Great. We have time for 2 more questions. So first, what lymphodepleting chemotherapy are you using on arm C?
The same as in arm A. So it's the standard regimen of fludarabine and cyclophosphamide.
Great. Okay. And so the last question is, how have the ALSF grants you received helped fund the research today? So are there any particular parts of the studies you presented today that came from ALSF grants, or how did this help contribute to some of the work you did
Yeah,
today?
absolutely. So actually all parts of the trial, both clinical, day-to-day clinical operations and correlative studies. So Alex's lemonade stand. Oh, and the preclinical work. So and the model development. Okay, so really starting back, Alex's Lemonade Stand Foundation helped us develop new models of spinal cord DMG. So my laboratory has made the first patient-derived culture and xenograft models of DIPG. We then made spinal cord DMG models from patients who donated their tumors to us. Alex's Lemonade Stand supported the development of that model, which was necessary to test the therapy in spinal cord DMG before opening that part of the trial. In the trial, we really have made, there's so few trials available for spinal cord DMG, and so we really made a concerted effort to always include those patients whenever possible. And Alex's Lemonade Stand Foundation helped us with that by expanding our clinical operations, CRC type of support, as well as supported the correlative studies, including the single cell sequencing studies, which I didn't show you in this talk because we are so actively analyzing that data and trying to understand what it means. But, we've now sequenced over 1 million cells from patient CSF and patient product. And we're learning an enormous amount. We're just very much in the weeds there. So next time I talk, I'll tell you about that. But Alex's Lemonade Stand Foundation helps support everything from model development, preclinical studies, clinical trial execution, and correlative studies. So, thank you for all of that.
Thank you, Michelle. I know, I think it's hard for Justin to see the chat as the presenter. So I know the very first question, I just want to make sure we ask it since they asked it so early in the chat, was for subsequent infusions, were new CAR T cells made from a new apheresis, or were some banked from the first infusion?
Great question. So our manufacturing team has worked out a method to save as many doses as possible from the initial apheresis. So, we can usually get something like 6 to 8 doses from one apheresis product. We also, when we do apheresis, we try to keep a second bag of the apheresis product to use again for remanufacturing. And so for the majority of patients, we were able to provide all of their doses from the initial apheresis, sometimes with a second manufacturing run. Sometimes we've had to repeat apheresis, especially when we get into like the 18 plus infusions, but we're usually happy to be in that position with this disease. So everybody's usually, happy to move forward with it.